All right, listener, ready for a deep dive into psychopathology. You sent over this chapter, and it's got me thinking, how do mental health professionals actually figure out, like what's going on in our heads?
It's like detective work, really. They use clinical assessment, a very systematic process for gathering all the information, all those clues to understand someone's, struggles, and then to determine if they meet the criteria for a psychological disorder.
Okay, so it's more than just asking what's wrong. It's like gathering evidence.
Yeah, exactly. And that evidence, well, that comes from a lot of different sources. Think interviews, observations, even brain scans. It's really all about putting those pieces together like a puzzle to form a clear picture.
I see, I see. Now, this chapter mentioned three key concepts for accurate assessment: reliability, validity, and standardization. Are those like the magnifying glass and fingerprint dust of psychological detective work?
Uh-huh. I love that analogy. So reliability means you get consistent results. Like if you step on a scale twice, it should show the same weight both times.
So it's about the tool being, dependable. What about validity?
Validity means that the tool is measuring what it's supposed to measure. So a scale measures weight, not height, right? A valid anxiety assessment actually measures anxiety, not just like general stress.
Gotcha. And standardization. Is that about making sure everyone's playing by the same rules?
Yes, it's about keeping things consistent, the same instructions, same scoring, no matter who's taking the test. That way we can compare results fairly.
Makes sense. So once you've got your reliable, valid, standardized toolkit ready, what's the first step in this psychological investigation?
Usually it starts with a clinical interview. It gives the clinician a chance to get a detailed history, understand the person's current struggles, and just generally get a sense of who they are.
Okay, so like getting to know the main character of our mystery novel. The chapter also mentioned something called a mental status exam. What is that exactly?
It's a way for the clinician to organize their observations during the interview. They're looking at things like appearance and behavior, like is the person fidgety? Are they making eye contact? They're also paying attention to thought processes. Are their thoughts racing? Or is their speech slow and disorganized?
So it's about looking for clues in how someone acts and speaks.
Right. They're also assessing mood and affect. Mood is the overall emotional state like sadness or elation. And then affect is how those emotions are expressed, through facial expressions, their tone of voice, things like that.
Oh, that makes sense. I always mix those up. Is there anything else they're looking at during this mental status exam?
Yep, two more categories. Intellectual functioning things like memory, attention, how well they understand information.
Yeah.
And finally, sensorium, which is basically their awareness of their surroundings. Do they know where they are, who they are, what time it is?
Okay, so all of this paints a pretty detailed picture of the person's mental state. And it reminds me of Frank, the case study from the chapter. He was struggling with anxiety and relationship issues, but the clinician picked up on some unusual behaviors during the interview and mental status exam.
Right. Frank had these eye-closing twitches and intrusive thoughts about seizures, and the clinician realized, this could be a sign of something more than just anxiety, perhaps obsessive-compulsive disorder, OCD.
It's like the first big twist in our mystery. This really shows how important observation is in this whole process. The chapter also mentioned physical exams. Why are those important in assessing psychological disorders?
Well, sometimes physical conditions can actually mimic or even contribute to psychological symptoms. Like, for example, thyroid problems can cause symptoms that are really similar to anxiety. It's like making sure we're not mistaking one suspect for another.
So it's about ruling out any potential medical causes. After the interview and physical exam, what's next in our detective's toolkit?
Behavioral assessment. This involves actually observing the person's behavior either in their natural environment or in a controlled setting.
Oh, interesting. So instead of just asking, do you lose your temper often,
Mhm.
you'd actually observe how they react in a situation that typically triggers anger.
Exactly. The chapter talked about a mother who underreported her son's aggressive behavior, describing him as simply not listening. But when the clinician actually visited their home, they saw the son throw a glass across the room.
Oh, wow. That's a great example of why observation is so important.
Yeah.
Sometimes people aren't aware of their behavior or they might downplay it, but there's more to behavioral assessment, I think. The chapter mentioned something called an operational definition.
Yes. It's about defining a behavior in a way that everyone can understand and measure. So instead of saying he's got a bad attitude, you define it as anytime he refuses to comply with a reasonable request from his mother.
Got it, got it. So it's about being specific and objective, kind of like having clear evidence that would hold up in court. The chapter also discussed checklists and rating scales. Those seem pretty common. I see them at the doctor's office all the time.
They are. They're standardized tools that help clinicians assess the frequency and severity of different behaviors, much more reliable than just relying on memory or impressions.
Like having a scorecard for our psychological investigation. Now, let's talk about the more specialized tools, psychological tests. What's the lowdown on those?
Psychological tests can help us understand personality, cognitive abilities, emotional functioning, all sorts of things. The chapter covered a few types, starting with projective tests. You've probably heard of the Rorschach ink blot test. That's a classic example.
Oh, yeah, the what do you see game.
Yeah.
That's always intrigued me. What's the idea behind those tests?
They use ambiguous stimuli, like ink blots or pictures, and the person describes what they see. The idea is that their responses reflect their underlying thoughts, feelings, and even unconscious conflicts.
So it's like a window into their inner world. This chapter also mentioned the thematic apperception test, or TAE.
Yeah, with the TAD you're shown a picture and asked to tell a story about what's happening. And these stories can reveal a lot about a person's motivations, their relationships, and underlying conflicts.
So it's like a mini psychological drama. Now, the chapter did mention that these tests have been criticized for their reliability and validity.
True, because the interpretation of the responses can be a bit subjective. They're often used more as a way to spark conversation and exploration rather than like a definitive diagnostic tool.
So they're like a conversation starter in our psychological investigation. What about personality inventories? Those seem a bit more straightforward.
They are. Personality inventories are basically questionnaires where you respond to statements about your thoughts, feelings, and behaviors.
Right.
And the most famous one is the MMPI, the Minnesota Multiphasic Personality Inventory.
The MMPI. Okay. I've heard of that one. What makes it so special?
It's super comprehensive, covering a wide range of personality traits and potential issues. And it's based on an empirical approach, meaning it's backed by tons of research.
So it's not just based on someone's opinion, it's rooted in evidence. That's reassuring. The chapter mentioned a fascinating case, James S. His MMPI profile revealed some interesting insights, right?
Absolutely. James S. was being evaluated for some very serious crimes, and his MMPI profile showed high scores on a scale that measures antisocial tendencies. So basically, his test results matched his real-life behavior.
Wow. It's like those crime shows where the DNA evidence confirms the suspect. Speaking of assessments, what about intelligence testing? That's a big one.
Intelligence tests are designed to assess cognitive abilities, things like problem solving, reasoning, verbal comprehension, things like that. And the IQ test is probably the most well-known one.
Right. IQ intelligence question. It's a score that compares your cognitive abilities to others your age, right?
Right. And it's important to remember that IQ scores are not the be-all and end-all of intelligence. They just reflect your performance on specific tasks.
So it's like a snapshot, not the whole picture. And factors like cultural background and language can also influence how you do on those tests.
Exactly. Besides the classic Stanford-Binet IQ test, there are also the Wechsler scales, which have versions for adults, children, and even preschoolers.
So there's a test for everyone. Now let's move on to something that sounds super high-tech, neuroimaging. What's the deal with that?
Neuroimaging lets us actually see the brain's structure and function. It's like getting a peek inside the control center. There are two main types: structural imaging and functional imaging.
Okay, break it down for me. What's the difference?
Structural imaging, like CT scans and MRIs, shows us the brain's anatomy, the physical structures. Think of it like a detailed map. They can help identify things like tumors, lesions, or any damage.
And functional imaging, is that about seeing the brain in action?
You got it. Techniques like PET scans and fMRIs measure brain activity by tracking blood flow or glucose metabolism. It's like watching the brain light up as it works.
That's incredible. And fMRI can even capture brain activity in real time, right?
Yes, it's like watching a movie of the brain as it processes information. Now, besides neuroimaging, there's another fascinating area: psychophysiological assessment.
Psychophysiological assessment. That sounds like a mouthful. What is that all about?
It's basically about measuring bodily changes that happen during psychological or emotional events. So think heart rate, respiration, muscle tension, even sweat gland activity.
Oh, so like if someone's anxious, their heart rate might increase or they might get sweaty palms.
Exactly. These physiological responses give us clues about their emotional state, stress levels. One common tool in this area is the EEG electroencephalogram.
EEG, that rings a bell. It's used to measure brainwave activity, right?
Yes. It's especially helpful for understanding conditions like epilepsy and sleep disorders. Psychophysiological assessment is also used in biofeedback therapy.
Biofeedback, isn't that where you learn to control your body's responses?
You got it. By monitoring things like your heart rate or muscle tension, you can learn techniques to regulate those responses and reduce stress or anxiety.
So it's like taking control of your body's dashboard. So far, we've been talking about understanding someone on an individual level, but to really get the full picture of psychological disorders, we need to look at the bigger picture, right?
Absolutely. That's where diagnosis comes in, figuring out if someone's symptoms match the criteria for a specific psychological disorder.
It's like putting a name to the mystery we've been investigating. And the DSM-5 is the big book of diagnoses, right?
That's right. The Diagnostic and Statistical Manual of Mental Disorders. It's like the Encyclopedia of Psychological Disorders. It provides a standard set of criteria for each disorder, making sure everyone's on the same page.
Okay, so clinicians all over can use the same language and criteria. That makes sense. This chapter talked about some tricky issues around diagnosis, starting with the big question, how do we even classify human behavior?
Yeah, it's a tough one. The chapter discussed two main approaches, categorical and dimensional.
Okay, let's unpack that. Categorical seems pretty simple. You either have the disorder or you don't, right?
In a purely categorical system, that's the idea. Disorders are seen as distinct and separate, like apples and oranges. But the dimensional approach, that sees things more as a spectrum.
Oh, so instead of black and white, it's more like shades of gray.
Exactly. With the dimensional approach, you consider the severity or intensity of the symptoms. So you might have mild, moderate, or severe depression, for example.
So it's about how much of something you have, not just whether you have it or not. What approach does the DSM-5 use?
It actually uses a blend of both. It's called a prototypical approach.
Prototypical approach.
Yeah.
What does that mean exactly?
It identifies the essential characteristics of a disorder, the must-haves, but it also allows for some variation in other symptoms. Like, think of it as a blueprint, but with some room for customization.
I like that analogy. So two people with the same diagnosis might have different experiences, but they both meet those core criteria.
Right. The DSM-5 criteria for major depressive disorder is a good example. You need at least 5 symptoms, including either depressed mood or loss of interest in things you used to enjoy.
But the specific combination of those 5 symptoms can vary from person to person.
Exactly. The prototypical approach allows for that flexibility. And remember those terms we talked about earlier, reliability and validity? Those are just as crucial for diagnosis as they are for assessment.
So with reliability, different clinicians should arrive at the same diagnosis for the same person. And validity means the diagnosis accurately reflects their actual condition.
Precisely. And the DSM has gone through a lot of revisions over the years to try to improve both reliability and validity.
It's like they're constantly updating the detective's manual. What were some of the big changes?
Well, DSM-5, which came out in 1980, was a big turning point. It shifted towards a more descriptive and atheoretical approach.
So instead of focusing on theories, they focused on observable symptoms.
Exactly. It was all about making things more objective and reliable. DSM-IV, which came out in 1994, refined things even further and introduced the multi-axial system.
Multi-axial system. Remind me what that was all about.
It let clinicians assess a person's functioning on multiple levels, psychological, biological, social. It was about looking at the whole person, not just their symptoms.
And then came DSM-5 in 2013, which is what we're talking about now.
Right. It included some important changes, like adding dimensional measures for some disorders.
So instead of just a yes or no diagnosis, clinicians could rate the severity of symptoms.
Exactly. It provides a more nuanced understanding of the person's condition. Another big change was the introduction of cross-cutting dimensional symptom measures.
Cross-cutting, so that means looking for common symptoms that can show up across different disorders.
Yes. Things like anxiety, sleep problems, those sorts of things. It's like looking for common threads in our cytological investigations. Speaking of investigations, remember Frank?
Yes. What does DSM-5 say about his possible OCD diagnosis?
It helps clarify the specific criteria he needs to meet and allows for a more systematic way to assess his symptoms. DSM-5 also emphasizes considering cultural influences in diagnosis.
That's important, right? Different cultures might express psychological distress in different ways.
Absolutely. The chapter mentioned ataque de nervios, a syndrome common in some Hispanic cultures that has some similarities to panic disorder.
It's like different languages for psychological distress. So DSM-5 is a powerful tool, but the chapter wasn't afraid to acknowledge its limitations.
Right, no system is perfect. One issue is comorbidity, where someone might be diagnosed with multiple disorders.
So it's like having multiple mysteries intertwined. What are some other criticisms of DSM-5?
Well, some argue that a dimensional approach would be more accurate and less stigmatizing, but others believe that categorical diagnoses are still helpful for communication and treatment planning.
Sounds like a complex debate with no easy answers.
It is, and the DSM will likely continue to evolve as we learn more. But enough about diagnosis for now. Let's move on to research methods.
That's a whole other world of investigation.
It is. Research helps us understand the causes, the treatments, and the progression of psychological disorders. It's like conducting our own psychological experiments.
Sounds exciting. What are the basics of research in this field?
Well, it all starts with a hypothesis, an educated guess about what we expect to find. We're always testing those hypotheses to see if they hold up.
Like developing theories for our psychological mysteries.
Mm.
And then we need a research design, right?
Right. Our research design is basically our plan for how we're going to conduct the study, what variables we'll measure, who our participants will be, what procedures we'll follow.
It's like creating a blueprint for our investigation.
Yeah.
What about the terms internal validity and external validity?
Those are about making sure our research is sound. Internal validity means we can be confident that what we're manipulating in the study is actually causing the changes we see. And external validity is about whether our findings can be generalized to other people and settings.
Okay, so internal validity is about making sure our experiment is well controlled, and external validity is about making sure it's relevant to the real world.
Exactly. The chapter explored a bunch of different research methods, starting with the case study.
Those are the in-depth investigations of individuals or small groups, right? Like a close-up look at a single piece of the puzzle.
Yes. They can be great for understanding rare phenomena, but they're not always generalizable to other people.
Then there's correlational research, which looks for relationships between things. But correlation doesn't equal causation, right?
Right. Just because two things are related doesn't mean one causes the other. Like, the classic example, ice cream sales and crime rates both go up in the summer. Doesn't mean ice cream causes crime.
Haha, right. There might be another factor, like hot weather, that's influencing both.
Exactly. And the chapter mentioned the link between marital problems and childhood behavior problems. It's like the chicken or egg question, which came first.
Or maybe something else is causing both. Correlational research can't give us those answers. Speaking of correlations, the chapter also talked about epidemiological research.
That's about tracking the patterns of disorders in populations. It's like the detective work of public health.
So it's about understanding how widespread a disorder is and how it's distributed among different groups of people.
Exactly. Now, the gold standard for proving cause and effect is experimental research.
That's where you manipulate one thing and see how it affects another.
Exactly. And the classic example is the randomized controlled trial, or RCT. That's where participants are randomly assigned to either a treatment group or a control group.
Like flipping a coin to decide who gets the actual treatment.
And that random assignment helps reduce bias and make sure the groups are as similar as possible. The best RCTs also use a double-blind procedure where neither the participants nor the researchers know who's getting what.
It's like a super secret mission to prevent bias. The chapter also mentioned the importance of outcome research and process research.
Yeah, so outcome research looks at the end results of treatment, like, did the symptoms improve? Process research tries to understand how and why the treatment works. What are the mechanisms behind the change?
So it's not just about whether it works, it's about understanding how it works.
Yeah.
What about single-case experimental designs?
Those involve studying one person or a small group. Over time, they're great for personalized assessments of treatment effectiveness. And one key feature is repeated measurements.
So instead of just looking at before and after scores, you're tracking progress throughout the treatment.
Yes. The chapter talked about Wendy, who was struggling with anxiety. Repeated measurements showed that her anxiety fluctuated a lot, regardless of the treatment.
Oh, so the treatment might not have been the main factor in her improvement.
Exactly. Repeated measurements gave us a more nuanced understanding of her situation.
What about those withdrawal designs? The chapter mentioned some ethical concerns with those.
Yeah. In a withdrawal design, you introduce the treatment, monitor progress, then withdraw it to see if the behavior goes back to how it was before. But sometimes it's not ethical to take away a treatment that's working, especially if it's for a serious condition.
That makes sense. We don't want to jeopardize someone's well-being just for research.
Exactly. Researchers have to carefully weigh the risks and benefits.
Is there another single-case design that avoids that ethical problem?
Yes, the multiple baseline design. Here, you introduce the treatment at different times, across different behaviors, settings, or individuals, And if you see improvement only after the treatment is introduced in each case, well, that's strong evidence that the treatment is working.
It's like having multiple pieces of evidence that all point to the same conclusion. The chapter also discussed a cool example of this with kids with autism.
Yes. They taught the kids how to communicate their needs instead of engaging in problem behaviors. And they found that problem behaviors decreased and communication skills increased, but only after the intervention was implemented for each child.
That's awesome. What about genetics and behavior over time? What kind of research is done in that area?
That's where we get into family, adoption, and twin studies. They help us tease apart the roles of genes and environment in psychological disorders.
Okay, so family studies look at how common a disorder is among relatives. If it runs in families, it suggests a genetic component.
But families also share environments, so you can't be sure it's all genetics. That's where adoption studies come in.
They compare adopted kids to their biological and adoptive families. If they're more similar to their biological family in terms of a disorder, well, it points to a stronger genetic influence.
Right. And twin studies are even more powerful, you see. Identical twins share 100% of their genes, while fraternal twins share about 50%.
So if identical twins are more likely to both have a disorder than fraternal twins, it suggests that genes are playing a role.
Exactly. The chapter mentioned a fascinating study on antisocial behavior using the Vietnam-era twin registry.
What do they find?
They found that genes played a bigger role in adult antisocial behavior than in juvenile antisocial behavior. So as we grow up and move out of our family environments, genes seem to have more influence.
That's interesting. What about those genetic linkage and association studies?
Those get even more specific. They're actually trying to identify the actual genes associated with disorders.
Like zeroing in on the exact location of a gene on a chromosome.
You got it. They can be very helpful, but the results need to be replicated and interpreted carefully. Now, all of these methods help us understand how behavior changes over time.
It's like watching a psychological time-lapse video. The chapter talked about cross-sectional and longitudinal designs.
In a cross-sectional study, you compare different age groups at one point in time.
Like taking a snapshot of different generations.
But the problem is that you might see differences that are due to historical or cultural factors, not just development. That's where longitudinal studies come in.
You follow the same group of people over time, like watching a movie of their lives unfolding.
Exactly. Longitudinal designs allow us to track individual changes and see how behaviors and disorders develop over time.
The chapter mentioned a longitudinal study on dairy consumption and weight gain.
Yes. It found that people who drank more milk and ate more dairy products actually gained less weight over time.
Wow, that's surprising. Longitudinal studies can definitely give us some valuable insights.
Absolutely. And sometimes researchers combine cross-sectional and longitudinal approaches in what we call a sequential design.
It's like getting the best of both worlds.
Exactly. It allows for a more comprehensive understanding of developmental changes while accounting for those historical and cultural factors.
Now, we've covered a lot of ground here, from assessment tools to research designs. It's amazing to see all the different ways we can investigate psychological disorders.
It is a fascinating field.
And it's clear that there are a lot of different factors at play: biological, psychological, social, even cultural.
Absolutely. Understanding all these factors is crucial for accurately diagnosing and treating psychological disorders.
Well, before we move on to part 2 of our deep dive, I want to leave you with a thought, listener.
As you think about all this information, what stands out to you? What aspects of this chapter are most interesting or relevant to you?
Take some time to reflect on that, and we'll continue our exploration in part 2. Stay tuned.
Welcome back, listener. We're picking up right where we left off, exploring the fascinating world of research methods in psychopathology.
I'm ready for more detective work. What intriguing concepts are we uncovering today?
Let's talk about phenotypes and genotypes. Remember Frank? Well, phenotypes are those observable characteristics we see in him. The anxiety, the unusual behaviors, the marital problems.
So phenotypes are like the outward expression of what's going on, the clues we can actually observe.
Exactly. Now, contrast that with genotypes. Those are Frank's genetic makeup, the genes that contribute to those characteristics, even if we can't, see them directly.
Genotypes are like the blueprints behind the scenes. So how do researchers figure out what role genes play in psychological disorders?
That's where things like family studies, adoption studies, and twin studies come in. They help us see if a disorder tends to run in families and how much of that might be due to shared genes versus shared environments.
Those studies are like comparing different versions of the same blueprint. And the chapter mentioned a fascinating concept: Endophenotypes.
Endophenotypes are like the missing link between genotypes and phenotypes. They're measurable biological markers that we think underlie specific symptoms or disorders.
So instead of just looking at Frank's anxiety, we might look for like underlying brain activity patterns or neurochemical imbalances.
Exactly. It's like trying to find the fingerprints of the disorder within the brain. But remember, even if we find a strong genetic link, it doesn't mean the environment doesn't matter.
Right, it's always a combination of nature and nurture. Speaking of environment, the chapter talked about how behavior can change over time and across cultures.
That's crucial to consider. What might be considered normal in one culture or time period? Well, it could be seen as abnormal in another.
The example of drug use patterns really stood out to me. What was once taboo is now more accepted, and vice versa.
Exactly. And the chapter emphasized cultural sensitivity in assessment and diagnosis. We have to be really careful not to misinterpret someone's behavior based on our own cultural biases.
It's like making sure we're reading the right cultural dictionary, so to speak. Now, what about prevention research? That seems like a whole different angle.
Prevention is all about stopping psychological disorders before they even start. It's a growing area of focus in mental health.
It's like trying to prevent the crime before it happens, rather than just solving it afterwards.
The chapter outlined 4 main categories of prevention: positive development strategies, universal prevention strategies, selective prevention strategies, and indicated prevention strategies.
Okay, I'm intrigued. Tell me more about these strategies.
Positive development strategies focus on promoting mental well-being in everyone. Think building resilience, coping skills, strong social connections.
So it's like building a fortress of mental health for the whole population.
Exactly. Universal prevention strategies also target everyone, but they aim to prevent specific problems, like those anti-bullying programs we see in schools.
It's like setting up a security system to keep those problems out.
Now, selective prevention strategies focus on groups that are known to be at higher risk for developing certain disorders.
So, for example, children of parents with depression might be offered a specific prevention program.
Precisely. And finally, indicated prevention strategies target individuals who are already showing early warning signs.
It's like seeing those flashing red lights and intervening before things escalate.
For instance, if a child is showing signs of anxiety, we might offer them early intervention with cognitive behavioral therapy.
This all makes so much sense. It seems like prevention research is using those same research designs we talked about earlier: cross-sectional, longitudinal, and sequential.
You got it. Those designs help us track risk and protective factors, see how things change over time, and ultimately figure out which prevention programs are most effective.
It's like testing out different crime prevention tactics to see which ones work best in the real world. Now, let's get back to the fascinating interplay between genes and environment.
It's a complex dance, but we're learning more and more about how those two partners influence psychological disorders.
We talked about heritability. That's the proportion of variation in a trait that's due to genetic factors. But even highly heritable disorders are still influenced by the environment, right?
Absolutely. Think of it this way. Genes provide the blueprint, but the environment can modify how that blueprint is expressed.
So even with the same blueprint, you can end up with different buildings depending on the materials and the construction process.
Perfect analogy. And the term epigenetics describes how the environment can actually change gene expression, turning certain genes on or off.
Wow, that's mind-blowing. So our experiences can actually alter our genetic code.
In a way, yes. And those changes can even be passed down to future generations.
This whole field is so complex and ever-evolving. It's exciting to see how much we're learning about the interplay between genes and environment.
Absolutely. And those genetic linkage and association studies we mentioned earlier are helping us pinpoint the specific genes involved in certain disorders.
It's like we're zooming in on the genetic code, searching for those tiny variations that might make someone more susceptible to a particular disorder.
Now, all of this research wouldn't be possible without careful attention to ethics. Protecting the well-being of our research participants is paramount.
You're absolutely right. We can't just conduct experiments without considering the potential risks and benefits.
The chapter emphasized informed consent. Participants need to understand what they're getting into and have the right to say no at any time.
And confidentiality is crucial. People need to trust that their personal information won't be shared without their permission.
Exactly. And researchers have a responsibility to minimize any potential harm, both physical and psychological.
We also talked about that tricky dilemma with placebo control groups. It's hard to balance the need for scientific rigor with the ethical obligation to provide, effective treatment.
It's a complex issue, and researchers have to carefully consider the risks and benefits in each case. There might be cases where comparing a new treatment to an existing effective treatment is more appropriate.
And even when using a placebo, it's crucial to have strong oversight from ethical review boards to ensure participants' safety and well-being.
Those review boards play a vital role in ensuring ethical conduct in research.
Now, besides those core ethical principles, we also talked about the importance of addressing bias in research.
Bias can creep in at so many stages, from how we select participants to how we interpret our data. We have to be vigilant and use rigorous methods to minimize those biases.
Things like random assignment and blinding can help level the playing field and make sure our results are as objective as possible.
And when we share our findings, it's crucial to be transparent about any limitations or potential conflicts of interest. Like, if a study was funded by a company that stands to benefit from the results, well, that information needs to be disclosed.
Transparency is essential for maintaining the integrity of research. Now, we also talked about conducting research with vulnerable populations. Those are groups that might need extra protection. Children, individuals with cognitive impairments, prisoners.
We have a special responsibility to make sure these groups aren't exploited or taken advantage of. We might need to get informed consent from both the individual and their parent or guardian, for example.
And our research methods might need to be adapted to meet the unique needs of these populations.
Finally, we can't forget about cultural sensitivity. Different cultures have different ways of expressing distress, seeking help, and even understanding mental illness.
We have to be careful not to impose our own cultural biases on our research. That could lead to misinterpretations and inaccurate findings.
It's all about recognizing and respecting the diversity of human experience.
Well, this whole discussion about research ethics has really gotten me thinking.
It's a crucial aspect of responsible research. And as we move forward in our understanding of psychological disorders, it's important to keep those ethical principles at the forefront of our minds.
Well said. Before we wrap up part 2, I want to leave our listeners with a thought-provoking question.
What are some of the biggest ethical challenges you think researchers face when studying psychological disorders? Take some time to reflect on that, and we'll delve deeper into those challenges in part 3.
Stay tuned for more. Welcome back to the final part of our deep dive into psychopathology. It's been a wild ride, from all those different types of assessments to the crazy complexities of research, and of course the huge importance of ethics.
It really has been quite a journey. And as we wrap things up, I think maybe circling back to those ethical considerations we talked about earlier, they really are the foundation of, responsible research.
Absolutely. I think it's easy to get caught up in all the fascinating science, but we can't forget about, the human element. We're dealing with real people's lives and experiences.
Exactly. And that's why those ethical principles we discussed, informed consent, confidentiality, protection from harm, they're not just boxes to tick. They're about treating our research participants with respect and dignity.
Informed consent, that's all about, making sure people understand what they're agreeing to, like the risks, the benefits, their right to, withdraw at any time.
And confidentiality is about safeguarding their privacy, their information. It's entrusted to us. We have a duty to protect it.
We also talked about, the importance of minimizing harm. We can't subject people to procedures that might cause them distress or have lasting, negative consequences.
And if we do need to use any deception in a study, we have to debrief participants afterwards, explaining the true purpose of the study and why the deception was, necessary.
Transparency and honesty are so important in maintaining trust with our participants.
Absolutely. And when it comes to research on treatments, that ethical dilemma of placebo-controlled groups is something we really have to grapple with.
It's tough, right? We want to make sure the treatment is truly effective, but we also don't want to deny people, potentially beneficial treatment.
Researchers have to carefully weigh those competing interests, make sure the use of a placebo is ethically justified. There might be cases where comparing a new treatment to, an existing effective treatment is more appropriate.
And even when using a placebo, it's crucial to have strong oversight from ethical review boards to ensure, the participants' safety and well-being.
Absolutely. Those review boards play a vital role in ensuring ethical conduct in research.
Now, besides those core ethical principles, we also talked about the importance of addressing bias in research.
Yeah, bias can creep in at so many stages, from how we select participants to how we interpret our data. We have to be vigilant and use rigorous methods to minimize those biases.
Things like random assignment and blinding can help level the playing field and make sure our results are as objective as possible.
Right, and when we share our findings, it's crucial to be transparent about any limitations or potential conflicts of interest. Like, if a study was funded by a company that stands to benefit from the results, well, that information needs to be disclosed.
Transparency is essential for maintaining the integrity of research. Now, we also talked about conducting research with vulnerable populations. Those are groups that might need, extra protection: children, individuals with cognitive impairments, prisoners.
Yeah, we have a special responsibility to make sure those groups aren't exploited or taken advantage of. We might need to get informed consent from both the individual and their parent or guardian, for example.
Right, and our research methods might need to be adapted to, meet the unique needs of these populations.
And finally, we can't forget about cultural sensitivity. Different cultures have different ways of expressing distress, seeking help, and even understanding mental illness.
We have to be careful not to impose our own cultural biases on our research, right?
Yeah.
That could lead to misinterpretations and inaccurate findings.
It's all about recognizing and respecting the diversity of human experience.
So I think we've covered just about everything from this incredible chapter, for all the different types of assessments to the complexities of research and the paramount importance of ethics.
It's been a whirlwind tour of psychopathology, and while we've learned so much, it's clear there's always more to explore. This field is constantly evolving.
And as we wrap up our deep dive, I want to encourage you, listener, to keep that curiosity alive, keep learning, keep asking questions, keep delving deeper into the mysteries of the human mind.
And remember, behind all the science and statistics, there are real people whose lives are affected by these disorders. Let's approach this field with compassion, empathy, and a commitment to, ethical research.
Beautifully said. This has been an incredible journey. Thank you for joining us on this deep dive into psychopathology. Until next time, stay curious.